Hi, this is Brian Shapiro. I am doing the lecture this week on photosensitivity disorders from LIVA. It's a relatively short chapter, so I've put together a little PowerPoint and then I've added some interesting cases, which I'm going to do. A little PowerPoint on photosensitivity disorders. So the photosensitivity disorders are three big groups: the drug-associated, the chemical-associated, and the immunologically mediated, which is the largest group. And those are the ones we're going to focus on today. And the types that we're going to discuss are polymorphous light eruption, actinic prurigo, hydroa vacciniforme, which are all well-defined entities, and then a kind of group called chronic actinic dermatitis, which is a mixed group of disorders and a kind of wastebasket for some of these UV-associated disorders. And lastly, solar urticaria, which is pretty straightforward and is well known to all. So let's start with polymorphous light eruption. This is a commonly occurring disorder, especially in the northern latitudes. It's usually symmetrical, it's non-scarring and presents with erythematous and itchy papules and plaques and vesicles, usually only in the exposed skin. It is non-scarring, and that's important, and the vesicles and papules can ulcerate. Important for the diagnosis of this is that there's a negative ANA and a negative porphyrin screen, because obviously lupus and porphyria have to be excluded. And in terms of the causation, UVB light is 50%, UVA light is 25%, and both UVA and B is the remaining 25%. Let's go on to the next slide. The pathology early on is spongiotic with lymphocyte exocytosis and a perivascular and periadnexal lymphocytic infiltrate. There can be eosinophils, so it's really not a specific histology. Little later on, you find this prominent papillodermal edema with a characteristic histologic findings and a tightly cuffed superficial and deep perivascular and periadnexal lymphoid infiltrate. So that is a more characteristic histology. The differential diagnosis of the pathology would be lupus, would be chilblains, and in these times, COVID. So we really do need the clinical. And then for the early diagnosis, the early histology, it's really not specific, so it becomes an issue. So I just wanted to go through the specificity of dermal mucin in this diagnosis of lupus, because when you compare to PMLE to lupus, one of the characteristics of lupus would be the mucin deposition as well as the CD123 cells collections in lupus. And there was a very good study from the University of Michigan which came out on looking at lupus, lichen planus, EM, and PMLE, and looking at the mucin deposition. And yeah, I'm just showing some pictures. The top is graft versus host disease, the middle is lichen planus, and the bottom is erythema multiforme, and this one is lupus. And you can see that erythema multiforme and even in lichen planus, there was some mucin deposition. So this mucin deposition is not entirely specific for lupus, and one must be careful when diagnosing PMLE early on. But if you just use a mucin stain to exclude lupus. In PMLE, this article showed you can find some strands of lupus of mucin. So here you have the prominent papillodermal edema, superficial and deep perivascular lymphoid infiltrate, and a colloidal iron stain highlighted some mucin deposition. This is a slide of an early phase of PMLE on the left with a spongiotic vesicle formation, some erythrocyte extravasation, and the early edema. And then this is the characteristic papillodermal edema you see a little later on. The next group we wanted to look at was actinic prurigo. This is an excoriated and symmetrical eruption, which is worse in the summer. The face and the distal limbs are most affected compared to PMLE, which affects the neck and limbs, but often not the face. And interestingly, you can have chylitis and conjunctivitis in this, chylitis in up to 60% and conjunctivitis into about 45%. of cases. The pathology of this is also not completely specific. You can have spongiosis with lymphocyte exocytosis. You can have a lupus-like interface. You can have chronic eczematous change. The interesting thing is cheilitis, you have lymphoid follicle formation. So that is a clue. If you see ulceration and what looks like cheilitis on the lips, and their lymphoid follicles, something to think of as actinic prurigo. So here are some pictures of actinic prurigo. This one is the characteristic distribution on the cheeks and above the lips. Here is a later lesion. And here is some of the cheilitis that you see. And these are all from DermNet New Zealand, which is an excellent resource for clinical and some histologic pictures on the net. Here are a case series published on actinic cheilitis, actinic prurigo with cheilitis, and here you can see the ulceration and some vesicle formation on the lip, and again an area of almost ulceration here, and a lymphoid follicle. You can see the germinal center and the cuff of lymphocytes around in this, and this is another publication of similar case, and again the clue to this is cheilitis with this lymphoid follicle in the germinal center. So this was interesting histology. The third group that we're going to look at was Hydroa vacciniforme, and the clinical of this is usually in children. It's a blistering disorder, and this one scars compared to PMLE, which is not scarring. Usually resolved by 10 years of age, and clinically you find hemorrhagic vesicles post-UV exposure, usually within hours. It often involves the ears, and this disorder called juvenile springtime eruption is probably part of Hydroa, and ulcerates and heals with a scar. So that's the clinical clue. The pathology early on, there's intercellular edema with vesicle formation, reticular degeneration, and then leads to epidermal necrosis with ulceration and a perivascular lymphohistiocytic infiltrate with neutrophils. And this can look very similar to awful Milker's nodule, where you have this reticular degeneration and a neutrophilic infiltrate, and you really need the clinical. In Hydroa, there's Epstein-Barr virus by in situ hybridization. So if the clinical fits and if you've got this available, you can demonstrate the EBV. The differential is a fairly newly described lymphoma, which is Hydroa vacciniforme-like lymphoma. And this looks fairly similar histologically, but the lymphocytes in the dermis are atypical, and there's some angiocentricity and maybe even some angioinvasion with this. So here are some clinicals from that same DermNet New Zealand of Hydroa, and again vesicles, ulceration. This one involves the ear, and you can see some crusting and hemorrhagic crusting. There's bulla formation. And here is some of the characteristic pathology, which is see ulceration, superficial and mid-dermal perivascular lymphoid infiltrate with neutrophils, which are not so easily seen here, but you can have a very dense neutrophilic infiltrate. And early on, you'd see reticular degeneration in the epidermis. This is a study in JAD of the Hydroa vacciniforme-like lymphoproliferative disorder. And these, you can see their papules and crusts in a young patient, didn't have much vesicle formation. And in this one, the histology would look just like Hydroa with this lymphoid atypia. And here is the pathology of this, and you can see a lot of edema, a Hydroa vacciniforme-like lymphoid infiltrate. But over here, EBV was positive, and some of these lymphocytes had lymphoid atypia with hyperchromatic nuclei and irregular nuclear contours. The last group we're going to look at was chronic actinic dermatitis, and this is a group of disorders. They all in common present in older males. It's a persistent photosensitive eruption with erythematous, edematous plaques, which can be lichenified. And the photosensitizers here include contactants and drug. In this group of disorders are things which were known as, or are known as, persistent light reaction, photosensitive eczema. Both those two are not really that specific. And then actinic reticuloid, which is a fairly specific histology in clinical. So let's look at persistent light reaction. This is usually associated with halogenated salicylamides, thiazide diuretics, musk, perfume. These can all sensitize the skin. And then you have an eczematous reaction in the area, and sometimes a more generalized out of the area that was sensitized by if it's a contactant. The pathology of this one is not specific, and it's an eczematous pattern. There can be ears and plasma cells. So as you can see, this can really look like a contact reaction. The next one was photosensitive eczema, and this is essentially a photocontact allergic dermatitis. You have to distinguish this from photoexacerbated seb derm or atopic derm, and that has to be done clinically because histologically, as you can see, you'll see some scale crust, irregular psoriasiform hyperplasia, some spongiosis, and a perivascular lymphoid infiltrate. So that really is not a specific diagnosis. And the third one was actinic reticuloid. This clinically can be a clue because you can have erythroderma, and histologically it can mimic CTCL. So in this one you have a band-like superficial lymphoid infiltrate with atypical lymphocytes and hyperchromatic nuclei, and then fibrosis in the dermis with stellate fibroblasts. And again, with this one, you can have plasma cells and eosinophils. So the histology looks like CTCL, but often you see sometimes these stellate fibroblasts, which are supposed to be a clue. And here's some pictures of actinic reticuloid. You can see this band-like lymphoid infiltrate, some what's almost epidermotropism with enlarged lymphocytes in the epidermis, and an occasional necrotic keratinocytes, and here the fibrosis of the papillary dermis and the stellate fibroblasts. So this, together with the characteristic clinical findings, would be good for actinic reticuloid. The last one I was going to speak about was solar urticaria, and solar urticaria is just histologically looks like urticaria and is induced by UV light. So there's not much we can show new histologically. Just vascular dilatation in the upper reticular dermis with margination of neutrophils and a very vascular mixed cell infiltrate, newts, sometimes ears. So that was the little talk on photosensitivity, and let's now move along to a few cases. First one I wanted to show you was this one. So here we had a punch biopsy, and I think it's best shown over here. Relatively normal stratum corneum, some spongiosis over here, not much lymphocyte exocytosis, a lot of papillodermal edema, and then a superficial and mid-dermal perivascular lymphoid infiltrate, which has focal erythrocyte extravasation, but not really eosinophils or plasma cells. So this, in the appropriate clinical context, would fit very well with polymorphous light eruption. You can see there's been some literature showing that lupus can have a lot of papillodermal edema. So people would, I would add a mucin stain here, and just with a caveat that you can see small amounts of mucin like this in polymorphous light eruption. I guess the CD123 clusters of lymphocytes would help, and if there was some interface, that would be lupus. And then you can see COVID, or if it's an acral site, pernio would be in the differential diagnosis. So that was the only case I got out of our teaching set for this chapter, which was unique for PMLE. And I thought I'd attended a Harvard conference recently on updating dermatopathology, and I thought I'd show a few things from there, and then a couple of melanocytic lesions, which are interesting, and then one or two other cases that people might find interesting. So let me just go back to our PowerPoints. So this was a conference out of Boston, a remote conference on updating DermPath, and Dr. George Murphy, who's an expert in melanocytic pathology, did a presentation which I found quite interesting, and Phil McKee, did presentations on melanocytic, and so I was going to just show some of these newer entities and then show some of how we deal with it. So some of these are were new terminologies for me. Dr. Murphy spoke about a lentiginous compound dysplastic nevus with age-related epithelioid change, and these are these dysplastic nevi where we see these epithelioid melanocytes. So that was a kind of interesting terminology that I had not seen before. Second thing that was interesting was there was a dysplastic nevus with an abundant nodal nevus in the sentinel lymph node. And here he had a case of a dysplastic nevus with all the bridging and concentric eosinophilic fibroplasia, shouldering like you see in a dysplastic nevus. And this patient had a sentinel node with extensive nodal nevus. So this is another potential pitfall. Another entity that a new name I saw was acrolentiginous melanocytic proliferation with age-related epithelioid change. And these ones are very difficult to distinguish from acrolentiginous melanoma. And these are the experts get these kind of cases in consultation where you see acral skin, predominantly single cells, and they're epithelioid. And this was an interesting entity. And then it gets even more complicated, where this was a case they characterized as deep penetrating nevus-like melanocytic lesion of unknown malignant potential. And I don't want to go into all the histology of this, but I just put this out there to show some of the new terminologies and how complicated this whole melanocytic area is getting. And as people know, there's not a lot of consensus in this. Dr. McKee put up an interesting slide, and that may reflect his training in the United Kingdom originally. And he said, for every melanocytic lesion, he thinks it should be required to have the age, symmetry, irregular border, color, diameter, evolution, site of the lesion, recent changes, and why was it biopsied, and the diameter as well. And in real life, in outpatient derm path, we often just get the clinical of Rudolph Melanoma. So this was what was shown at the conference, and I'm going to show a few cases now that we have of melanocytic lesions, just to show how you could go to these conferences and learn all this stuff and still struggle with these things. So the first case, so this was a case of an adult patient with sun damage, I think in their 50s, on the arm. And it was a melanocytic lesion, and you can see it's nested intraepidermal component. Starts in a nest. Look around, ends in a nest. There's significant pleomorphism of the melanocytes, of big melanocytes, big nucleoli, dusty cytoplasm, significant upward growth over a very large area. There's melanocyte in the granular layer. There's one in the spinous layer. Irregular pigment. Some of them have got granular cytoplasmic pigment, others dusty cytoplasmic pigment. Melanocytes in the granular layer, which should not see in a Spitz nevus usually, unless it's a pagetoid Spitz. And then in the dermis, nests of similar cells with a patchy lymphoid infiltrate. I couldn't find mitoses. And this case has had a lot of different opinions. Some people say it's a Spitz tumor, unknown biologic potential, spitzoid melanoma, atypical Spitz nevus. Look at the upward growth here. And this case is being sent out for further evaluation and maybe even genomic study. The new stains we tried here were, this is P16, and P16 is preserved in the cytoplasm. It's kind of weak in the dermal component, but it's still there. And then we tried PRAME in this, and the PRAME stain, which was supposed to be a big help in diagnosis of melanoma when it started, is negative in the intraepidermal and has a blush in the dermal. So stay tuned. We are waiting for the experts at UCSF to weigh in on this case, and as I say, they might have genomic markers, but this just shows how difficult these spitzoid things can be. Another one I've got, let me just get this number. So this was an adult patient with significant sun damage, came in with a lesion on the thigh, and clinical was Rudolph Melanoma. Again, it's a relatively symmetrical lesion with some epidermal hyperplasia, large, very irregularly nested with large and small nests and some big dermal nests. When we go on higher power, each field looks the same. They're spitzoid cells with big nuclei, central distinct nucleoli. Not as much upward growth as the last one, but definitely some. You see it up here in the granular layer. And then these very, very odd-looking nests, and almost a Camino body over here. Not much maturation towards the base in terms of the cytology, because the cells on the bottom look exactly the same way as the cells on the top. And this case, again, had varying opinions. Some people thought it was a melanoma, lack of maturation, these strange nests. There was a mitotic figure found. Let me see if I have the P16 stain for this one. Here's the P16. Which was again preserved in the cytoplasm, but not that nice nuclear staining like you see in classic spits. And the PRAME stain was, I think, negative. Back to the slide. So these are the kind of cases they get varying opinions. This one was sent out, and at UCSF they did the antibody NTRK1 stain, and this was diagnosed as a fascicular Spitz Nevis in a 70-year-old patient on the thigh. And I just put this here because, as you see with Dr. Murphy's presentation and this, the whole field is really moving with genomics and with antibodies to some of these translocations that are now available. And I've got to the stage where we can diagnose these Spitz nevi in 70-year-olds in sun-damaged skin, or, you know, the experts can. And so I think this can save a lot of angst in the patient if you get to this diagnosis. Okay, the last melanocytic one I wanted to show people was, let's just come to this, CT25260. And this was an adult patient with a lesion on the arm. And this also had a spitzoid morphology. And this also had a translocation on the immunohistochemistry. So this was another adult with a Spitz. I think I've got one more case here. This was a very interesting case, also in melanocytic pathology, which was, I think it was a 60-year-old with also an upper arm lesion. When you look at this case, it's relatively normal epidermis. It's a dermal process. Got nests of smallish melanocytes in the upper reticular dermis, pushing into the up into the papillary dermis, and then a spindle cell proliferation admixed with it. So this was a real puzzler, because could this just be a combined nevus? Or is this a kind of desmoplastic melanoma in an adult patient with a mixed nevocellular pattern. And we stained this one up as well, and all the stains showed was that these spindle melanocytes, these spindle cells were melanocytes. There's some mast cells there. Couldn't find much mitotic activity. You obviously look for lymphoid follicles because that's a sign of desmoplastic melanoma. But this again generated varying opinions, from an unusual desmoplastic melanoma to a combined nevus. And this case was again seen by the melanocytic experts at UCSF, and they diagnosed this as a combined nevus with features of desmoplastic nevus and nevocellular or ordinary nevus. And this just shows how you can look at these cases every day and still be challenged by these melanocytic lesions. So the last case I wanted to show you was another issue in inflammatory, where a few weeks ago we had an interesting case. Let me just get this case right. This was a case that came in on the back, and it was actinic rule-out squamous cell carcinoma. It was an adult patient, and let's get to this case. And it was a shaved biopsy. It had a little scale here. Spongiosis, a little bit of acanthosis, perivascular infiltrate. Not much to see. Here's some more spongiosis, even formation of an early vesicle, lymphoid infiltrate, some lymphocyte exocytosis. Here's an eosinophil, and not much to see. So I got this case, and I thought, well, maybe this is an eczematous reaction, a bit of a glandular eczema in the back. I did a PAS stain to see if it's fungus, and that was negative. And we cut some levels. And here are the levels. And the level sections were kind of interesting, still shows the spongiosis. But then there were areas on the second slide here where there was some enlargement of the basal keratinocytes. Over here you see these keratinocytes are enlarged compared to, look at that area, for instance, compared to that area. Or this area here. This shows it nicely. These small keratinocytes here, and you see the bigger ones right here. So this, and some parakeratosis on top. So maybe this was squashed, we could squash this into an actinic keratosis. And this was biopsied as a squamous lesion, and there is a little bit of atypia. And the clue to the diagnosis here was, yes, this could be called an actinic, and you've got enlarged keratinocytes and parakeratosis. But it's only at the edge, and the good clinicians that do these biopsies would usually biopsy the lesion in the center. Anyway, it turned out while I was mulling over this case, the clinician called up and said, no, this is a rash and it is expanded, and this turned out to be the herald patch of pityriasis rosea. So this is a real case of the herald patch of pityriasis rosea, which I had never had such good clinicopathologic correlation. And it was biopsied as a squamous lesion because it was just a single lesion, and then by the time it had ruminated, having a PAS stain and trying to make this into an actinic, it manifested itself as PR. So, and if you look at the low power, you can see as a PR-like scale with mound-like parakeratosis and scale crust, and even some erythrocyte extravasation early on. So this was an interesting case, and this has been a kind of shorter chapter, but I hope people have learned something. And any questions, let me know. And if people want the article on mucin as a discriminator of PMLE versus lupus, let me know and I will send it across. So thank you very much for joining.